let me remind you again that for the evaluation from the QR code to join the lucky draw, and also for the tomorrow workshop, anyone who join the tomorrow workshop, the morning session workshop will start at 8 o'clock in the morning. The registration will start at 7:30 on the fourth floor of the Surintra building. And the one who join afternoon session workshop will be start at 11:30. Start with the lunch symposium first at the same floor, fourth floor, Surintra building. Okay. So we still have another very interesting session. Then the moderator will be Dr. Prani, as in the first session. Okay, please, Dr. Prani.
Me again. Hello, welcome again. It's me again. You. Let me introduce the speakers for last session. So the next lecture, the speakers will be Professor Billy Herr. He's a professor in. He's a director of Department of Pain Medicine, Division of Anesthesiology and Critical Care, the University of Texas, MD Anderson Cancer Center. Professor Billy Herr kindly, with his team, come to Sirat Hospital this year, and he joined our lecture for 2 days and non-stop, and he's still with us for the last session. So please give a big round of applause. Welcome, Professor Herr.
Thank you. Looks like we have intrathecal pump reserved for the last day. And when you think about the patient for intrathecal pump, it naturally is most difficult patients. Okay, when they are getting intrathecal pump consideration, that means they have already failed all the other therapies. Okay. Medication, pharmacotherapy, physical therapy, even spinal cord stimulator. Okay, so this, in terms of a hierarchy, this is the bottom. Okay, that means you are seeing the most difficult patient. Okay, and this is not for everybody. It is only for the patient who is refractory to any other treatment. Okay, so also very expensive, okay, and very invasive. So I have nothing to disclose. I don't have any relationship with the companies. So today we will look at the history of intrathecal drug, patient selection, okay, which is very important because if you are too aggressive and select the wrong patient, you are wasting a lot of money and you are doing total disservice to the patient. Okay. And how to do trial and screening and what intrathecal drugs to use. Okay. And also briefly mention implant and explant technique. Just knowing how to implant is not good enough. You really need to know how to explant too. Okay? Because there are times when you have to replace the pump. The patient needs the whole system removed if there's an infection. And that is very important because this is not like a stimulator where you can just remove it, you're done with it. This has a very large implications in terms of infection. So you really need to know how to remove the system also. And we're also talking about intrathecal pump complications. So intrathecal morphine goes a long way. It started in 1900 when they used the morphine and the cocaine. Remember, cocaine is local anesthetic, a combination for surgery. Okay. In 1976, UC San Diego, Tony Yax, he did a rat study, intrathecal study. And human testing was actually done in 1979. Okay. And the first Medtronic pump programming was implanted in 82, and the Synchromed 1 was introduced in the market in 1991. Okay. So currently we are using Synchromed 2. So why intrathecal delivery? Okay. So intrathecal delivery, mainly because it provides drug right to the target. Okay? There's no waste. Now, when you take a medication by mouth, how much you actually get delivered to the target? 0.0001%. Very tiny amount. Okay? So when you deliver a drug by intrathecal catheter, it's 100% bioavailability. You're not wasting any. So it's very efficient. Okay? And by giving lower dose, overall lower dose, you avoid side effect. Okay? Compared to systemic drug. Okay? And we have you used to have a number of pumps made by several companies, but now we have only few. And Medtronic practically dominates the market now, okay, because it's only programmable pump. And it's convenient because it can be easily refilled and programmed. So what are the indications for neuromodulation? When we say neuromodulation, we have talking about stimulation and the intrathecal pump. Okay? So neurostimulation, we have certain diagnoses such as radiculopathy, neuralgia, ischemia, okay? And then intrathecal delivery, okay? Cancer pain, somatic pain, some other chronic pain. Okay? But there's also overlap. Okay? You can go either way, stimulator or pump. Okay? But rule of thumb is stimulator is less of maintenance. Intrathecal pump is high maintenance. So therefore, we recommend you do stimulator trial first. Okay? So stimulator, when they fail, then think about intrathecal pump. Okay? So intrathecal pump is bottom of a hierarchy, last resort. Okay? So what are some rationale for intrathecal infusion? Okay? One of the easy rationale is if patient cannot tolerate the oral opioid. Okay? Side effect, or it's not effective, okay, and also increase the quality of analgesia. Okay, and we can use certain agents that only can deliver to the intrathecal, okay, and also avoid high dose opioid. So just look at the short and long term side effect of opioid. Okay, when you compare the two. Not only short-term, especially long-term, intrathecal delivery of opioid has significantly less side effects. Okay? Now, biggest problem with opioid is GI side effects. Okay? Look at the long-term intrathecal, virtually devoid of side effects. Okay? So this is one of the compelling reasons why intrathecal can be used if the patient has a problem with the systemic opioid. Okay. And also cancer pain. Okay. When patients failed oral or IV opioid due to side effects, but patient has to have at least greater than 3 months life expectancy. Okay, just not cost effective to give it to somebody who's not going to live more than 3 months. Okay, and make sure that anatomy is suitable. Okay, if there's an obstruction of a CSF flow, they're probably not a good idea to put it in. Okay, and neuropathic pain is one of the reasons why we tend to use pump, because neuropathic pain is a very difficult pain for us. Okay, what are some of the oral medications we have available? There's only 3 drugs: pregabalin, gabapentin, Cymbalta. That's it. Okay? There's no other FDA-approved drug. Okay? Sometimes we use tricyclics, but it's very limited. Not only that, these 3 drugs' efficacy is not very good. When the FDA approved the gabapentin for neuropathic pain, you know what the efficacy was? 30%. That means 70% of patients did not respond to the gabapentin. Okay? But why is it approved? Because we didn't have anything better. Okay? And also it's very safe. No one dies of gabapentin overdose. So what are patient selection criteria for non-cancer patients? Okay? In fact, in the United States, more non-cancer patients get intrathecal pump than the cancer patients. Okay? And only when more conservative therapy has failed and pathology is concordant with the pain and no further surgical or any serious untreated psychological drug habits, psychological issues and only had a successful trial. Okay? If they do not have a successful trial, they will not get it. An insurance company will demand that. So before you implant intrathecal pump, you have to have imaging studies, okay? Because we need to know where the catheter will be, where the catheter will be introduced, and check for the any kind of tumor or cancer, okay? So if this is a patient here with a C-spine stenosis, critical stenosis, catheter will not go up, okay? So make sure that you don't have any patients with a critical stenosis. What are some of the factors that affect the distribution and absorption of intrathecal drugs? There are several. One is patient, okay? Second is spinal fluid factor. Third is how you inject the drug, okay? And fourth is drug itself. So patient factor, age matters, okay? Different ages, they have a different physiology, okay? Drug clearance, metabolism, okay? And CSS flow. Height matters. Tall versus short, okay? It really impacts how drug is spread. Okay? Obese patients have the different anatomy, okay? And if you have a patient with a very high intra-abdominal pressure, such as the obese patients, they will also have a very high intrathecal pressure. Okay, so it will impact there's dynamics of drug spread and efficacy. So what are the CSF factors? So intrinsic property of CSF, okay, specific gravity, baricity, and how the CSF flows. Okay. Injection technique, especially during the trial. Okay, now, a lot of us now do single shot intrathecal injection. Okay, now location matters. Okay? You want to inject where the pain is. Okay, you don't want to inject far from the pain. When they have a cervical pain, shoulder pain, you don't want to inject lumbar. Okay, and rate of injection. You push fast, then it has turbulent flow. It will spread more. Okay, you inject slowly, then it's not going to spread that far. Because how you inject really matters. So also drug factor. How fat soluble is drug? Okay? How water soluble is drug? Okay? More water soluble they are, more they will spread. Okay? And how much you give. Okay? You give large, you will spread more. Okay? Also volume of distribution. So characteristic of drugs. Okay. Hydrophilic drug. Example, morphine. Now, how many of you think morphine is really hydrophilic? So if suppose you have two partition, okay, oil and the water separated with a membrane, and you put the morphine on the top, which compartment will you go? Will you go to oil or water? You will go to oil, because morphine is actually lipophilic. Okay, you look at the partition coefficient of morphine; it prefers oil. Why are we saying it's hydrophilic? A lot of anesthesia textbook will tell you that it's hydrophilic. It is not correct. It is relatively speaking, it's hydrophilic compared to hydromorphone and fentanyl. Now we totally miss the point that morphine is actually hypophilic into lipophilic. Okay, so but relatively speaking, it's more hydrophilic. Okay, so that's something that we really need to keep in mind. Okay, so hydrophilic drugs, relatively hydrophilic drugs, do not cross blood-brain barrier readily. Okay, high CS concentration at the infusion site, and it is distributed by bulk flow. Okay? And when you inject the drug, there will always be concentration gradient. You inject the drug in lumbar area, lumbar will have higher concentration, thoracic have a little less concentration, cervical will have much less concentration. That concentration gradient will be always there. Okay? And when it's relatively more hydrophilic, it's cleared from CSF slowly compared to the lipophilic drug. So how about lipophilic drugs, such as fentanyl and hydromorphone? Okay? When it's a lipophilic, it doesn't spread very much because our, in the epidural space and intrathecal space, there's a lot of fat. So it will absorb quickly, and you get a segmental analgesia. You don't get a diffuse analgesia. Okay? And it doesn't reach a whole lot into the cervical area. So it is very useful if you want to just limit your analgesia segmentally. So what is the advantage of a continuous intrathecal infusion? Okay. So when you have a continuous infusion, you have constant concentration in the CSF. Okay. There's no such thing as up and down. Okay. When you use short-acting opioid, what happens? You get a peak, and then 3 hours later, you bottoms out. Okay. That's why we prefer extended release form, so they have a constant level. Similarly, if you have a continuous infusion, you maintain the constant CSF level. Okay. And it's more predictable concentration gradient because you reach a steady state. Okay. And when you maintain the constant level, you generally have a less side effect. Where does the side effect come from? Usually bolus. When you give a big bolus, you get a huge peak. That's where you get a side effect because the level exceeds analgesic area level, and you get a side effect level because it's too high. Okay, that's why you want to avoid big boluses. Okay. So when you look at the morphine and looking at the concentration gradient, okay, so it's high variability. Okay, if concentration is about 4 to 7 times higher at lumbar than the cervical. Okay? Baclofen, anywhere from 2 to 9 to 1. Okay? So baclofen, if you look at the bigger number, okay, so baclofen has a much higher concentration gradient. So if you want to put a baclofen for specificity, your catheter has to be closer to the target. If they have an arm specificity, catheter tip has to be close to the cervical area. Okay? On the other hand, clonidine is little less. Okay? You don't have to be exact target. It will spread much better. So there's a number of ways to do intrathecal trial. Okay? You can do intrathecal catheter trial, which is very accurate. It predicts exactly what starting dose will be. Okay? But intrathecal catheter trial has a lot of problem. Okay? Number one, CSF leaks, headache, infection risk. Okay? So a lot of people are trying to avoid that. You can do epidural trial. Put the catheter in the epidural, and you can run it for a day or two and find what is dose requirement, okay, and how much pain we live to get. So that can be done, but this requires hospitalization. They need to stay in the hospital. They cannot do it as an outpatient. So what's more popular nowadays is one-shot, single-shot intrathecal bolus shot. Okay, so at the outpatient, we give a one shot, we watch them for a few hours, and then we get how much pain relief they get, and they send them home. Okay? And even they can report it next day, how much pain relief they got overnight. Okay? So 50% reduction in pain is benchmark to proceed with implant. So what to monitor during the trial? Okay? Of course, reduction in pain. Okay? 50% reduction is the benchmark for insurance coverage. They will not pay unless they get at least 50% reduction. Functional status. Okay? How much can they do more? Can they clean the house? You know? Can they walk longer? So these are the things that we have to see, okay, and document during the trial. And are they still using a lot of breakthrough medication during the trial? Okay? So another thing to watch, medication usage. So some of the intrathecal drugs that we use nowadays, some of them are FDA approved, some of them are not, and some of them are off-label use. Okay? So in opioid, morphine is gold standard, okay? FDA approved. Hydromorphone, fentanyl, meperidine, and not too many people use meperidine. Non-opioid, baclofen, local anesthetics, clonidine, okay, and calcium channel blockers for the neuropathic pain. So some of the opioids we use commonly are morphine, hydromorphone, fentanyl, and sufentanil. Okay. Morphine is FDA approved, as I mentioned. It's relatively hydrophilic, okay, and not detected in the bloodstream for 2 hours because they stay in the CSF a little bit longer than other opioids. Fentanyl and sufentanil you give it is almost instantaneously become intravenous. Okay? So there's not a whole lot of difference between putting it intrathecally versus IV. Okay? And the morphine equivalent dose, 300 milligram PO equal to 100 milligram IV, 10 milligram epidural, and 1 milligram intrathecal. So it's 300 to 1 ratio. Okay? So by doing intrathecal, you give 300 times less amount of drug. Okay? And because it's a relatively hydrophilic, slow spread to the, and then there's also delayed respiratory depression because it comes out of the CSF slowly. So they have a biphasic. Okay, so delayed respiratory depression can occur if you give a single shot opioid of morphine. Okay. And steady state reached in 72 hours. And as mentioned earlier, lumbar to cervical concentration ratio is anywhere from 4 to 7 to 1. Hydromorphone, also known as Dilaudid, is a little more lipophilic than morphine. Okay? It is used very commonly in the United States for intrathecal, mainly because it has more favorable side effect profile. Okay? A lot of people complain of side effect with morphine. Itching, okay, is one of the major problems with the morphine. Okay? But hydromorphone is a very clean drug. It's synthetic, okay, little more lipophilic and more potent. It's 5 times more potent than morphine. Okay. So fentanyl and sufentanil is only reserved for the patient who doesn't do well or has side effect or allergy to the morphine or hydromorphone. Okay? Generally, I do not recommend this because they're highly hydrophilic. Okay? So there's no particular difference between giving intrathecally versus IV. Okay? Especially sufentanil, because so lipophilic drug. It has a rapid onset because of the lipophilic, and it gives a segmental analgesia. Okay? And nevertheless, long-term infusion has been very favorable. Okay? And effective doses are anywhere from 10 to 100 micrograms for fentanyl, and 12 to about 80 micrograms per day for sufentanil. Okay. So this I'm gonna just skip. So one thing you need to know is once you know the concentration of decide on concentrated drug, there's a lowest limit how much you can give. There's a limit what lowest dose pump can infuse. Okay, so for that, first factor is 20. Okay, if you have a certain concentration, let's say morphine, you pick the 10 milligram per ml concentration, lowest amount you can infuse, and you divide it by 20 is 0.5 milligram per day. Now, if patient is having a profound side effect with 0.5 milligram per day, now you have to change the concentration. Okay? So this is number you really need to remember. Okay? Factor of 20. But you can even go lower than that. The only way is use a minimum infusion rate. Okay? The pump cannot be turned off. Why? If you turn off the pump, you ruin the pump. Okay? Because so the pump always had to run at the minimum rate. Okay, that's an absolute lower limit. Okay, the minimum rate is about 10 times the lowest infusion rate. They could be 0.05 milligram per day. Okay, so in the emergency cases, you use a minimum rate until you change the concentration. Okay, because patient is not doing well with the lowest rate infusion. So typically, single shot trial dose, we use morphine at the 0.15 to 0.5 milligram, okay, depending on how opioid tolerant they are. Hydromorphone, 0.04 to 0.1, you call it 40 mics to 100 microgram. Okay, fentanyl, 10 to 25 microgram. Zirconotide, which is a calcium channel blocker, is anywhere from 3 to 5 microgram. Okay, and baclofen is typically 50 microgram. Okay, you can go as high as 100 microgram, but typically they do well. You can get a lot of information out with only 50 microgram injection. So this is a poly-analgesic consensus published in 2012, and this is what they recommend for intrathecal bolus. Okay, so I mentioned this already. And maximum concentration of morphine, they do not recommend more than 20 milligrams per ml. Okay? There's a reason for that. Okay? And these are the list of maximum concentrations they recommend. And this recommended high maximum concentration came out because of granuloma formation in the tip of catheter. Okay? So any higher concentration, you're running into chance of developing granuloma tissue, which can create a lot of problem for patient. So this is pump drug concentration. This is typically what I use, hydromorphone from 5 to 10 milligram per ml, morphine 10 to 20. Okay. What you want to do is, if you're not sure, always go with a lower number. Okay, lower number. Clonidine 100 microgram per ml, zirconotide 25 microgram per ml. Okay, zirconotide 25 microgram per ml is the stock solution coming out of manufacturer. Okay. If you want anything lower, your pharmacist has to dilute it, which I do not recommend. Okay. So 25 microgram per ml is usually good enough. So when you divide that by 20, starting dose 1.2 microgram per day. Okay. Baclofen comes in two concentration, 500 mic and 2,000 microgram. Okay. So if a patient is has a spinal cord injury, and you want to choose lower concentration. Okay, so I forget this one. So local anesthetics is also used commonly, although it is not FDA approved or Medtronic manufacturer recommended drug. Okay, but nevertheless, it has been used for so long by the implanters, the pain people, that it's basically accepted standard of care. Okay. Mechanism of action, of course, is sodium channel blocking. Okay, stabilizes C fibers, and we have extensive experience as an anesthesiologist. We use it in epidural, nerve blocks, okay, and it's fairly effective for neuropathic pain. Okay. So when the patient is not doing well with the opioid, single agent opioids, a lot of times we add local anesthetics. Okay. So typically, most commonly used is bupivacaine, okay, anywhere from 2 to 30 milligrams per day. It is synergistic with the opioid when you combine it. Okay. It's fairly stable. Concentration is about anywhere from 5 to 40 milligrams per ml. Okay. And it is fairly effective for cancer, non-malignant, as well as neuropathic pain. So other local anesthetics, although not commonly used, you can also use bupivacaine, but tetracaine is not recommended. Okay. Alpha-2 agonist. Okay. In the good old days, when we didn't have a zirconotide, we often used the clonidine when opioid alone did not take care of cancer pain. Okay. Because alpha-2 agonist has analgesic effect, okay, similar to epinephrine. Okay. So you stimulate alpha-2, you get a synergistic effect with opioid. Okay. It's very effective for neuropathic pain. Okay. So clonidine as well as the dexamethasone is available nowadays, and you have to be careful that you don't overdose this because you can lower the blood pressure. Okay. And you don't want to exceed 400 micrograms per day. Okay. And the other drugs, baclofen, is not exactly for pain, but it's for spasticity. Okay. And prior. Okay. So when you encounter refractory neuropathic pain, first thing you want to do is try opioid. It doesn't work, you can either add local anesthetics or clonidine. When that fails, zirconotide. Why zirconotide later? Because it's so expensive. This is 20 cc vial costs $4,000. Okay, so it's a very expensive drug. But it can be very, very effective. Okay, this is zirconotide is found in the sea snare of the Philippine island. It's a toxin, neurotoxin, and it can be only introduced just through the pump intrathecally. Okay, if you take it epidurally, intravenously, or orally, you get degraded by the enzyme. Okay, it's useless. So mechanism of action is calcium channel blocking, okay, especially neuronal calcium channel. Okay, it has very little impact on the cardiac calcium channel. It is 25 amino acid peptide, and it causes a calcium channel direct block. Opioid does indirect block calcium channel, but this does the direct block, okay, and inhibits release of neurotransmitter. So it is clear through the elimination half-life is about 4.5 hours. Okay. And let's go through this. And it was FDA approved in 2004. Okay. So it's been around for about 15 years. And zirconotide is a fairly safe drug, but it has a profound side effect, okay, especially in CNS. Sometimes they hallucinate. Okay, they feel weak. They have blurred vision. Okay, so it has a profound CNS effect. That's why it's very important that we start out is very low dose as lowest dose possible. No higher than 1.2 microgram per day, and titration has to be slow. Okay, very narrow therapeutic windows. So we have to go up very, very slow. Okay, I want to increase the rate more than once a week. Okay. Maybe 5 to 10% increase. And maximum dose recommended by the manufacturer is 19 microgram per day, but I have personally never exceeded 6 microgram per day. Okay. So look at the outcome, the cancer pain and non-cancer pain. Okay, zirconotide has been very effective for both cancer and non-cancer, especially the neuropathic pain. Okay. And so when the 2007 Pali consensus paper came out, they put the zirconotide as first-line drug. Okay, so first-line morphine, hydromorphine, and zirconotide. Okay, and second line is fentanyl and other combinations. But zirconotide is so safe. In fact, there has one case report where they accidentally gave one single bolus of almost 900 microgram, okay, and patient was not arousable, but patient was breathing on his own, okay, and eventually patient woke up, no brain damage, nothing done. Okay, so it's very hard to kill a patient with zirconotide. Okay, very safe. So zirconotide was one of the latest intrathecal drug approved by FDA, and in last actually about 30 years. Okay, it is very effective for chronic patient. No tolerance. You can use it for long term. Patient never developed tolerance to this drug, and you can abruptly stop. No withdrawal. Okay, and there's no respiratory impact. So this is a fairly safe drug, but it's very pricey. Okay, and it's relatively unstable drug. So we do not recommend mixing with other drug. Okay? Look at the drug. When you combine with clonidine, it barely lasts 1 month. Okay? Bupivacaine, 3 weeks. Okay? Hydromorphone, barely 3 weeks. In other words, zirconotide will degrade if you mix it with the other drugs. Okay? So stability is issue. Okay? But if you put zirconotide by single agent, you can last 6 months, no problem. So baclofen is analog of GABA. Okay, so it is a GABA agonist, and it's used for spasticity with patient with any brain injury or spinal cord injury. Okay, and when it's indicated when oral baclofen is either not effective or it have too much side effect. Okay? So this can be a game changer for the patient with spasticity. Okay? Do you give a 50 microgram intrathecal test dose, they will be able to walk for the first time without a pain. They are so spastic and they can just walk like a normal person. Yeah. So it can be a game changer for these people. And those of you who are doing physical medicine rehab, you do see a lot of these patients. So baclofen single dose trial, typically I use 50 microgram. Okay, and when we started in the continuous infusion, we started 50 microgram per day and titrate up slowly. Yeah. So baclofen has side effects that you really need to know. Okay, there's a side effect from overdose, and there's a side effect from underdose. Okay, some of the overdose, nausea, vomiting. Okay, and then one of the most problematic is seizure. Okay, they can get into coma. Okay, well, if you abruptly stop or pump run out of medication, it's much worse than opioid withdrawal. Okay, they can have a hyperthermia, hypotension, mental status changes, go back to the being very spastic, and organ failure and seizure. So they can have a seizure from withdrawal and overdose. So sometimes you don't know which is which. Okay? So the one thing that you want to make sure they don't get into is the baclofen withdrawal. That can be deadly. Okay? So also, as we, last 20 years, as we see a lot of patients with intrathecal pump, there have been long-term complications. And one of them is buildup of granuloma tissue at the tip of catheter. Okay? And when tip of catheter develop granuloma tissue, it is because of inflammatory cells deposit at the tip. Okay? These drugs are infused very, very slowly. Okay? When you're looking at the 0.3 mils per day, okay, that thing is coming out so slowly. Okay? So that you develop a concentration gradient at the tip where the inflammatory cells come and attach and they build up. Okay? When that happens, guess what happens? Tips get stuck to the nerve, spinal cord, and they develop arachnoiditis. And they complain of now radicular pain. Okay? So one of the main reasons for development of granular tissue is concentration. More concentrated drug it is, more likely to develop this kind of tissue. Okay? So that's why there's a maximum recommended concentration for each drug. Okay? So you should adhere to this recommendation to avoid this. So when you take an MRI, look at this. Tip has a large granuloma tissue built in. Okay? And the intrathecal pump and MRI. When intrathecal pump is exposed to magnetic field, guess what happens? Pump stops. When they come out of MRI, pump resume pumping. Okay? But 99% of the time, it pumps, resume pumping, but few times it doesn't resume. Now patient will have a big problem, especially baclofen. Okay? So therefore now the company issues recommendation, anyone who goes under the MRI needs to see pain specialist within 24 hours to ensure that motor stall has not occurred. Okay? So polyanalytic consensus conference was held in 2017. And so what they said was the risk to benefit ratio for intrathecal delivery drug is relatively safe, okay, for both cancer and non-cancer. So it's not just limited to the cancer pain anymore. Okay? So they came out with a recommendation. And compared to the long-acting systemic or oral medications, opioid, it's very safe. Okay? In fact, 19,000 die annually from opioid overdose. None of them died from intrathecal opioid overdose. And Medtronic published their own performance report. Okay, because when the device goes wrong, we replace it. Medtronic takes it back, and they take it apart and analyze it. Okay. So 1 year after implant, what they saw was less than 16% of the physicians used label drug. They used a lot of off-label drugs, okay, not recommended by the FDA. Okay. After 5 years, only 6% use label drug. 94% use something other than recommended drug. Okay. So when they look at the pump failure rate, 5 years, when they use on-label drug, failure rate is 2.8%. It's almost double when they use non-label drug. Okay. So and then one institution, there was like almost 10% failure rate. Okay. And between 2000 and 2013, almost 200,000 pumps were implanted in the United States. Okay. And of those, about 7,000 has been registered. And when they look at those pumps, almost 60% was for non-cancer patients. Okay. And 22 were for spasticity, and about 19% for the cancer patients. So the vast majority of the pump is implanted for the non-cancer patients. Okay. And as of July 2015, there was a malfunction rate of about 2.4%. Okay. 1% due to the motor stall, okay, and about 0.3% due to the gear corrosion. Okay. And less than 1% due to the internal pump tubing problem. Okay. So gear corrosion is because some of the non-FDA approved drugs cause corrosion of the inside. Okay. So when you withdraw the residual drugs, they actually look yellow because they cause rust inside the pump. So when Medtronic recommended that we only use FDA-approved drugs, physicians responded. Okay, the Pali consensus guys, they wrote another article. This is a response to the Medtronic position, okay, using the off-label drug. Okay, so what these guys who've been putting intrathecal pump for many, many years, they got together and they say, some of the compound drugs, it's almost like a de facto standard of care. Okay, we have a lot of experience. Patient safety is preserved, and we never, many of them think that it's still safe. Okay, and the overall risk of motor pump stall is very low, regardless whether you use FDA-approved or non-approved drug. Okay, and also sometimes it is necessary to use off-label drug. Okay. So what they are saying is just to be aware this can happen, and vigilance is much more important than using, strictly adhere to the FDA-approved drug. So I want to mention briefly about implant technique that we're going to do tomorrow. Okay, so everybody has a different style, and if you go to, there's 3 stations in the cadaver lab, everybody will teach slightly different technique. This is my way of doing it, and this is my 20 years of doing this. Okay, so first is, you position the patient laterally, okay? And you palpate the iliac crest and the end of your rib cage, okay? And that's where my catheter will be tunneled. Okay? I don't want to tunnel it over the bone, okay? And then where does the pump goes? I'm going to put it in the abdomen where pump does not put a pressure on the bladder. Okay? Some people will have a problem urinating if your pump is sitting on the top of bladder. And also, they will complain a lot of pain if top of pump is irritating the bottom of your rib cage. So you want to put it just in between, okay? So you palpate the rib cage, and you don't want to be too close to the rib cage or too close to the bladder. Okay? So you just temporarily, draw the little pump here and draw the line, because I'm going to follow the line to tunnel the catheter from the back. And then I'll go back there, draw the line, and that's where my anchor site will be. Okay? So I can make a straight tunneling. If I put a pump high up here, it's going to be oblique angle. Okay? And I just look at the fluoroscopy and put a marker, and it's going to be what? Never do these things midline, always paramedian. So when you look at the perfect AP view, pedicle is where your skin entry will be. Okay. So we made incision right over the pedicle. Okay. This is L12, L23, so the 2 needle will be, so your spinous process is somewhere here, right here. Okay, so it's a little bit right side paramedian approach. And we cut down to where we see the fascia. Okay. So fascia means the fascia that covers your lumbar muscles. Okay. So if you cut through fascia, guess what do you see? You're going to see meat, red meat. That means you cut too much. Okay? You don't want to cut through the muscle. Okay? Never cut through the muscle. So here we have a spinal needle, 14 gauge needle. Okay? Now we're doing paramedian approach under fluoro guidance. Okay? So this is a AP view. So it's going to be paramedian. Okay, so that's the pedicle. Your target is epidural space target is here, inner space. You're going to be at least one vertebral level below. Okay, skin entry will be right at the right side of the pedicle. That's where your incision will be. Skin entry with the needle is the top of your incision. Any incision above your needle entry, total waste. Okay, so just below the incision, the needle entry. And this angle of a lateral angle should not exceed 30 degrees. Okay? And also, this vertical angle should be no higher than 45 degrees. Okay? And now looking at this here, okay? The paramedian approach, needle is coming in, this is your inner space. Okay? Boom. When you pop through the dura, you see CSF flowing. So you're in there. Okay? And you put a catheter in. And now you follow with the fluoro. And here's catheter. Okay? And you go typically T9, T10. Okay? So here it is. You can see the catheter. Okay? And you want to check the lateral view also. Why? You want the catheter to be posterior to the spinal cord, not anterior. Okay? Because all the sensory fibers are in the posterior side. Okay? So you want that guide catheter posterior to the spinal cord. Okay? So now once the catheter is where you want, then you put anchor, okay? And suture to the fascia. Okay, so we just secure to the fascia. And then now we're making pocket for the pump, okay, in the abdomen. Okay, so we already have a diagram. So we usually want to, this is a pocket. So, think about your pocket in your pants, okay, where you can put your hand, okay. So from side, the pocket needs to go in. So a lot of people make incision, horizontal incision, okay. So that makes it a little difficult to tunnel the catheter. Here, we can see catheter coming in easily. You can lift up the skin, it comes right out. If you make incision here, you cannot see where you're tunneling, how deep, how superficially you're tunneling. So my recommendation is you make a vertical incision. Okay? And then you undermine it this way. Okay? And you can tunnel it from one shot. Okay? Your tunnel should be bent about half moon, and then you can go in like this. And once you reach the apex of your side, you turn it side. You can still make a directional control. Okay? And then once you're over the hump, you turn it upside down. Go this way. Okay? So you can do a one shot without making any more puncture. Okay? One shot tunneling. And once you do that, you put the catheter through the tunnel and remove it. Okay? And then keep feeding. So you can see there's a one shot tunneling from the back to the abdomen. Okay? So there's a catheter and remove the tunneler. Okay? And now you prepare the pump, fill the drug, and you put the catheter in there. And so, the pump, you can put in the pump in the pocket, but you want to secure it so it doesn't rotate or flip over. Okay? The pump can rotate and it flip over and pull all the catheter down. And some people have a bad habit of rotating their pump. That's like they have nothing better to do. Okay? And then you wind up with a catheter right next to the pump because they pull it all the way down. Okay? So that's why you want to secure it to the fascia. So there's a little, when you look at the pump, there is a little hook there where you can put a suture. And the suture, you don't want to make it tight either. Okay? You want the pump to move freely. Okay? Just don't let it rotate. So if you secure the pump to the floor of the abdomen tightly, guess what happens? You're going to put a lot of pressure on the bladder. Okay? So you don't want to make a tight security to the floor. Just make a very loose string so it doesn't flip or rotate. So there is, you see there's a suture there. Okay? And here we're putting another hook to the suture to the hook there so to keep it from flipping or rotating. Okay? And there's now at the end, we make sure all the excess catheter is behind the pump and put it in. Okay? And make sure there and then staple it, suture it and staple it. Okay? And success. So this is this was like 12 years ago, my fellows. So there's a complication. Whenever you do surgery, complication. Yes, infection. Meningitis can occur because our catheter is straight to the brain. Okay, so if there's an infection, you gotta take it out. Okay, whole thing needs to come out. Okay, granuloma formation can happen, bleeding, CSF leak can happen. Okay, so you can see sometimes infection like this. Okay, and this needs to come out. Whole system has to come out. Okay, bacteria seized on this kind of devices, we will never be able to eliminate with antibiotics. They have to come out. Okay. Catheter kinking can occur. Okay, now the new generation catheter is much more stiffer, so the kinking is minimal. But when it's stiff, guess what? You can also cause a lot of nerve damage when you're advancing the catheter. So you have to be very careful. It can disconnect, dislodge, break, migrate. Okay, battery depletion can occur. Internal pump failure can occur. Okay, now first generation catheters easily kinked because they are very soft. Okay, once it kinks, you have a lot of problem. Okay, sometimes pump can continue to pump, and it can just deliver the medication. But the kink is very severe. Guess what? Patient will come to you and say, I have a cycle of sedation and withdrawal. Okay? So because of kink, pump is developing certain amount of pressure in order to overcome the kink. Okay? So during that time, patient getting absolutely no drug. When enough pressure builds up, boom, it pushes through the kink and they get overdose. Now they get sedation, and then it takes about 1 week to build up the pressure, they get a withdrawal. So whenever you see a patient complaining overdose and withdrawal, that means they have a severe kink, and you got to replace it. Okay. So I mentioned patient can rotate their pump and pull the catheter out. Okay, so put a suture through it. Okay. Now, if you put the catheter too close to midline, spinous processes will contact each other and act as like seizures, and you cut the catheter. Okay. That's why you don't put it right through the spinous process midline. Never do that. Okay. Same for the spinal cord stimulator. You cannot put it midline. Okay. So, other complications, medication related. Of course, with a pump opioid, you can always have to worry about the respiratory depression with overdose. Okay. So one of the relative contraindication for pump implant is a patient who is living too far from medical center. Okay. They live 5-6 hours. Then if something happens, big problem. They cannot get it fast enough. Okay? So it is a relative contraindication. If they're living middle of nowhere, Texas is huge, United States is huge. So we have a lot of people living in the middle of nowhere. Access to the hospital takes a long time. Okay? We actually had one case where our nurse practitioner increased the baclofen by 5%. Okay? Because the patient was a little more spastic. But the 5% at 50 microgram per day and 800 microgram per day, that's a big difference in 5%. Okay? So this patient was getting 800 microgram per day, and she increased 5%. And patient went home, cannot walk, hard to breathe because all the muscles are too relaxed. So we had to come back to hospital in 4-hour ambulance drive with the airway ambu bag. Okay? So this kind of thing can happen if they live too far. Okay? Of course, other medication-related side effects includes constipation, nausea, urinary retention, hormonal. With a prolonged exposure to opioid, a lot of people have a loss of libido. Okay? So that is well known because their endocrine do change. The testosterone level go down. Okay? So this is some of the common complaints with the chronic use of opioid. Okay? So the pump is very expensive. Okay? So in the United States, it will cost them $50,000 to implant this. Okay? But when do you recoup this cost? Initial cost is high. Okay, this was what 1997. Now it's like $50,000-$60,000. Okay, when do you recoup this high initial cost? According to this study, you gotta keep the pump for at least two years. Then it becomes cheaper Okay? Because you don't go to see doctors, you don't use any other medications, so the lot less visit to the emergency room. Okay? So that's when break-even point is. So in the long term, this is actually cheaper. So insurance companies know this economics. That's why they approve this at the United States. Okay? And for cancer patients, this study, they showed that they actually can live longer too. Okay? Perhaps because less stress, okay? And they have a better psyche. They are less depressed because their pain is a lot less. Sleep better. Okay? And as important as implant is removing explant. Okay, so there, if you put these things in, there will be times where you have to remove it. When patient has infection, you need to remove it. Okay, now if catheter has been sitting there for more than a month, you will develop granuloma tissue and capsules, scar tissues around the catheter. Okay, now you have a nice, thick granuloma or capsules around the catheter, extending from fascia to the dura. Okay, so the dura can leak out. You remove the catheter, now you have a nice conduit that leaks CSF. Okay, so you cannot leave that hole open. They will develop headache and infection, meningitis, and your wound will be dehisced because of CSF constantly leaking. Your skin suture will be broken down. Okay, it's set up for infection. Okay, therefore, when you're removing the catheter, you have to mark where the catheter is at fascia. Okay, put some suture through it, then remove it tight. Make sure it's watertight, and ask anesthesiologist to do a Valsalva maneuver. Increase the, intracranial pressure to make sure CSF is not leaking. If it's leaking, you have to throw little more suture and make sure it's watertight. That way, they don't develop meningitis. Okay, so that's very important. Things to remember when you're removing. So conclusion. So intrathecal pump is indicated when conservative therapy has failed. Okay, it's not for everyone. Refractory pain. Okay, and efficacy can be improved with the careful attention to detail. Okay, medication selection, appropriate dose. Okay, and good surgical technique is very important. Okay, and these patients needs frequent, regular pump maintenance, refills, okay, reprogramming according to their pain. So I know you guys don't do this too frequently, but when you do, these are things that you must remember. Okay, so with that, I take any questions.
Thank you, Professor, for your very informative lectures. This topic is relatively new for us. So do you have any question? Anyone have any question? อาจารย์ปราโมทย์ค่ะ
Thank you very much for your informative and practical for us. And I have the question. I have a patient with sarcoma at the hip and the mass very big. She can't walk. She needs to lie down and with very intractable pain. We have tried many types of opioids and other medication, and she's still quite painful. Now, I still making a decision whether should I do the intracranial opioids or maybe mix with some local anesthetic, or shall we do epidural therapy?
Yes, so if you do epidural catheter therapy, you can, it's simple, okay, but you can, it's externalized. So
Yes.
it's
Yes.
problem with a long-term problem. So you can actually tunnel it and keep it up to about 1 month. Yes, so during that time, it's a fairly simple procedure. So you can buy time. So they can make a decision whether patient can afford this kind of device, or insurance will pay, or so you can buy time with a simple tunneled epidural catheter, because when oral medication don't respond, sometimes you have a very difficult time managing their pain, and they need to be admitted with IV morphine. But that's very expensive. So what we do is for those type of refractory pain, rather than admitting them into hospital, in the clinic we can do simple epidural catheter placement and the tunneling, simple tunneling, and then they can go home. And I can get a portable pump, but it's a little bit of a maintenance. Sometimes we have a home health nurse go to their home and exchange the bag, the epidural bag, or they can come to clinic if they live close by, and we can change their bags. Okay? So that's a temporary measure. If they stay they're hospitalized, very easy. We have epidural pump, you can do it. So that's a temporary measure, but it's not something that you can long-term solution. So intrathecal pump is the long-term solution.
I'm not sure which one is more effective, because if we use the epidural infusion, we can use higher dose of
That's
local
right.
anesthetic.
Yeah.
But if we do the intrathecal pump, even we use quite a high concentration of local anesthetic, but it may not get the pain relief
That's right.
much because it's quite painful.
That's right.
Like,
So
and
the-
it's located in one side.
Right. So intrathecal is the opioid is the main therapy. Local anesthetic is adjunct.
Yeah, it's
Adjunct.
adjunct.
So it cannot be because too much of local anesthetic, they get profound motor block. Okay, so it cannot be a primary drug. Okay, so once the patient has a pump, then you are much more flexible. You can always try the other drugs. So you don't have to keep doing lumbar puncture on this patient. So you can start with the opioid. You can add the clonidine. You can order local anesthetics, but they're all failed. A lot of times, they're clonidine.
Unfortunately, in Thailand, we don't have the clonidine for intrathecal,
Intrathecal.
and also we don't have the secondatide as well.
I
so
see.
it's
So what you can do is actually you can do single shot spinal block with the opioid.
yeah.
Okay, see how much relief they get, and that is a good prognostic testing for whether they will do better with the intrathecal opioid. Okay, since you don't have also you have access to local anesthetics, you can add the local anesthetics. Okay, so that local anesthetics has an opioid sparing effect, so you can use less opioid. Yeah.
And another one question, if you have the patient with like chronic obstruction and patient have the very severe chronic pain, intrathecal morphine or intrathecal therapy can help in this condition or not?
So that intrathecal morphine will not promote the parasympathetic activity. Okay, epidural local anesthetics will promote, because they will be much better, in my opinion. So they can get a temporary epidural placement. They will promote the bowel movement, and also get a good analgesia. Because opioid will slow down bowel. Okay, so local anesthetics in epidural will promote the bowel movement. Okay, so avoid constipating the patient when we already have obstruction. Yeah. So also, when you have obstruction, you have to be really careful of promoting bowel movement, because so you got to know what is cause of obstruction first, before you put epidural or do something, So, but then certainly opioid can worsen the obstruction. Yeah. So whether it's a mechanical obstruction or what,
Ramon, are there any more questions? Or anyone want to discuss? Please.
I have patient with cervical myelopathy at C3. After the decompression, he has still burning pain and some spasticity. Is that a good candidate for intrathecal, and what drug we use for this?
Yes, if they have a refractory spasticity,
Yes.
upper extremity, baclofen trial is certainly warranted. But you have to try the oral baclofen first. Okay, if they respond, they don't need a pump. If they don't respond with the dose titration, then intrathecal trial is warranted. Yeah, so to always try with the oral medication first.
And for burning pain?
What?
Burning pain.
Burning pain.
Yes.
Well, burning pain is a sign of a neuropathic pain.
Yes.
So baclofen is not the answer. Spasticity, baclofen. But when they have a burning pain, then you can try the, clonidine is one thing. And you can, sometimes the opioid helps too. Okay, but
Combine.
Opioid can help with some neuropathy to some degree. But if they don't respond to opioid, then you can try clonidine, and ultimately you can try the zirconatide. Zirconatide works very well for the neuropathic pain, but it's, as I said, it's very expensive.
And some local anesthetic maybe?
Local anesthetic can help too, yes. Yeah, local anesthetic is used for neuropathic as an adjunct, but a lot of times the intrathecal medication, we don't use the local anesthetic as a sole agent, always as adjunct.
Okay, thank you.
Any more questions? So I would like to ask, we have alpha-2 agonist, we have dexmedetomidine. So do you have any experience of using dexmedetomidine for cancer? Usually we only use dexmedetomidine for the anesthesia or intensive care patients.
Yeah, so I'm an old-timer. So when I was doing residency, we never, even dexmedetomidine was not available. So I don't have and then once I finished my training, I didn't do any anesthesia. Okay, so we don't have a whole lot of experience using that, because back then when the zirconatide was not available, we used clonidine, okay, local anesthetics. So I don't think too many people have experience using dexmedetomidine as an intrathecal drug. And the availability of zirconatide in the United States, with not too many people are using alpha-2 agonist, because it has impact on the blood pressure. Yeah.
Okay, yes. In the market in Thailand, intrathecal pump still very expensive, but nowadays the company have the product intrathecal delivery system. Can you compare the intrathecal delivery system and the pump? Like for us, the pump maybe is too expensive, but like how about intrathecal delivery system? Is it more suitable, or have you got experience for the patient? The inter is like the port with the catheter. It's not like the just ordinary epidural, but it's just more like the delivery system is like the proper port and then tunneling, but it's not a pump. Ajahn Nut, have you had experience for that?
So it's not internal. The catheter is externalized.
Like the way to put it is the same as epidural, but the system is more like it's more durable than epidural, the conventional epidural.
So there was a very similar product we have in the United States. We call it a Dupan catheter.
Right.
So it is epidural, but it's we can keep it for 6 months because it's mostly internalized, and at the port is almost like a Hickman's catheter.
Right.
So it has antibiotic cup, so it can stay for about 6 months. So that's one answer, because it's relatively cheap. So it's epidural, but it is because it's epidural, volume is high, so it's a high maintenance.
Yes.
They need to carry a big bag.
Yeah, compared with intrathecal pump is around like 100,000 baht.
Yeah, so
but
this is a much.
intrathecal pump is like millions, right?
Yeah.
Ajahn Phonpan, do you have experience to share about the
So that's
intrathecal pump?
I think the lifespan of the patient is like you can cut point, like if the life expectancy of the patient less than 3 months, so we consider epidural catheter in terms of cost effectiveness.
Yes, I think
and
that's
more than 3 months, so
yes.
we consider
We actually had a patient. We put the tunnel epidural because the patient was actually a 17-year-old small girl with a big sarcoma in the belly, and it's excruciating pain, and it certainly does not respond to opioid, oral opioid. So as an emergency measure, we just put a tunnel catheter, epidural catheter, right at the bedside. Put it blindly, and that's tunnel it with another 2 needle. Okay? And it lasts for 1 month. And then after 1 month, catheter became very, very flimsy, and it kinks readily, so we just replaced it. So you can actually do it and keep it for at least 1 month. Yeah. And they do really, really well with the tunnel epidural catheter.
Okay, Thank you very much. Are there any more questions? Okay, so I think everyone must be tired, but thank you all the participants. We still have all the big audience here until 4 o'clock on Wednesday, on Tuesday here. So thank you very much, all the participants. So please help me thank Professor for the very great presentation and great information. Yeah. So Ajahn Saraset will tell you some more about the tomorrow.
Okay, I have something to announce. First of the certificate still on the front desk. If anyone is still not received it yet, please go there and contact it. And for the tomorrow again, we have 2 sessions in the morning and in the afternoon. In the morning, we will start at 8 o'clock on the 4th floor of the Sunitara building, not this building. Okay, and the afternoon session will start at 11:30. Start with the lunch symposium. And before the end of the session, I would like to invite Ajahn Pramod to do the lucky draw for 3 lucky persons to receive our memorial T-shirt. Please.
ใครเป็นคนกดอาจารย์
Ajahn Prani also. Not this name yet. Okay. Not yet.
F9 ค้างไว้
So Lisa, no.
อาจารย์ยัง
Oh,
Not
so hopefully
yet.
no, not yet.
So the first lucky person will be
อาจารย์อยากอยู่ตรงไหน
1, 2, 3. Kita.
Gita is our pen fellow from Laos. Okay.
Yeah.
He's always lucky, get all the prize.
คนที่ 2
Okay, for the second one.
Okay, next one. So maybe all the participants is waiting for this session, right?
1, 2, 3.
ฉัน
คุณ
คุณ
ชันธนา
แพทย์หญิงฉันธนาหม่องเจริญพงศ์ค่ะ ค่ะ ยินดีด้วยค่ะ
And the last one,
อาจารย์ปราโมท
the shirt will be
bring luck to everyone สมบูรณ์ Oh. So actually all of them were pen fellows from the 3 big university hospital. Okay, good luck for all of them.
okay.
So อาจารย์สารเศรษฐ์ please.
On behalf of the conference organizer, I would like to express my utmost gratitude to our delegate, our distinguished speakers, participants, to join our conference, to share our valuable experience to help our patient take care, our pain management. Hope you enjoy our conference, our food, of course, and see you again tomorrow for the one who will join the workshop. And last but not least, take care and have a safe trip. Thank you.
May I invite Professor to give the